Good afternoon, friends. I know everybody's excited. It's been a fantastic day. Let's all find a chair, preferably next to somebody you don't know. Meet a friend. Good afternoon. I hope everybody has had a fantastic day. So learning, sharing, connecting with each other, and also hopefully challenging the speakers. We welcome that. I think that's very important. We see it every day in our practices in medicine, and we're welcome to that here as well. So we're going to close off the day with a closing plenary, and everybody's always, of course, interested, as we said this morning, in what's next, what's new, what's coming, what's a cure that maybe is on the horizon. So we're going to focus on, if I can get the first slide up. So we briefly said this morning, of course, we're always excited about new ideas, new options, new treatments, because many of you are well, and we've heard some people, like our dear friend Sharon Proudfoot, had this 23 years. Others have lived many years with this as well. And yet, nobody lives easily or well with the medications we have. Obviously, nobody is cured, other than if you're lucky and get lung transplant or perhaps surgery for blood clots, chronic thromboembolic PH. So we need to do more. And it always makes me think, you know, one of the hardest things for us as healthcare providers, all of us at the podium, is we want to do the best we can for each patient that comes in, obviously safely, with not too many side effects, but keep them as well as we can for as long as we can. As you all know, it still is a disease that we haven't cured in most people. It is a disease that progresses, and sadly, it is often fatal. And I know we've had a difficult time this year in London. Several of our long-standing patients who are very, very big, strong parts of the community, part of the London support group, passed away, one of them after 28 years of living with pulmonary hypertension. So very challenging. And I know you saw this last night. Some of our biggest supporters and advocates and people who grew us are people who have lost loved ones to pulmonary hypertension. Darren Bell with his son, Steve Van Wormer with his son Lucas. And so those people bring such energy, it's amazing. So because all of us have been touched by this in one way or another, we've either heard about it or lived it or us shared it as care providers, we're going to take a minute just to remember those that have this past year lost their battle with pulmonary hypertension. Thank you. It is important, when you lose a loved one to PH, you are still part of our community. And you see that. Jeanne Gendron, her son didn't pass away from PH, he got transplanted. He's doing amazing 10 years later. She is still a big part of our community. And so we welcome you to be part of us if you've lost someone or they've moved on from PH, and definitely use your knowledge, your skills, your energy, and help us build the next generation of PHA Canada. So with that, let's talk about the new and exciting stuff that's going on research-wise. And we'll jump into this, and I'll introduce my three panelists in a second. Many of you know this. You've heard a lot about this. All the drugs that we've developed over the last 25 years really fall into what we call the three key pathways. And these are the scientific ways that pulmonary hypertension develops. And we have medications that target all of these. So the first one there is excess endothelin. We all make a little bit of endothelin. Patients with pulmonary hypertension make a lot more, and it causes not only the spasm of arteries in the lungs, it also causes all the changes, the scarring that happens that we'll chat about in a second. And so we're lucky. We have medications that block endothelin. Had them now since 2001, the first one. We also know that most of us with healthy lungs make a lot of nitric oxide, NO, and also another chemical known as prostacyclin. And those are really, really important. They not only keep the blood vessels of the lungs open and blood flowing normally, they also tell cells, behave yourselves, don't make new cells. And so it's working in us. If you don't have those, which patients with pulmonary hypertension have less nitric oxide and less prostacyclin, all of a sudden it's like a colony of rabbits. They start to proliferate. They start to grow and make more rabbits. So these cells start to make more cells, and the blood vessels go into spasm. And we're lucky we have medications that work to replace nitric oxide in some ways and to replace prostacyclin, as many of you know that are on it. So those are the classic three pathways that we've known about for 25 years. And as you know, we've talked about this morning, amazing 10 medications, all in those pathways over the last 25 years. And when you go see your physician, they have a wealth of options to offer you. They're going to pick out what's best for you, ideally not too many side effects. And as many of you know, one medication isn't enough for most people these days. It's going to be 2 medications to work better, and sometimes even 3 medications. It's a bit of guesswork. I don't know that you are going to respond to this drug and that you're not going to respond to it until I try them. And that's a very big angle for the future. We're going to talk about that a little bit. It's all based on, obviously, our genetics, what determines who we are and what drugs might work and what side effects you might get. So we'll chat about that. So you have all these medications, and I don't want to scare anybody. It's still a bad disease. So on the bottom, the yellow curve is what this disease used to be before we had medications. Classic data from the 80s into the 90s from a very large registry in the US, the NIH. And this taught us that this was a terrible disease. The average person on that curve, 50%, lived 2.5 years. And that sadly still applies if you don't get diagnosed or if you don't get treated or if you might not respond to treatment, which luckily it's not that common. Most people respond. We don't have a lot of current data, but the data at the top, the purple curve, of course it's in purple, is the best recent data we have, and it's excellent in a sense of showing you that curve doesn't even get to 50 after 7 years. So that means the average person is living longer than 7 years. We now believe it's in the ballpark of 10 years or longer for the average person. And some people, as you've heard, live 20 years, 25 years. The longest survivor in the US is at 35 years. Sadly, it's not everybody. So that curve is coming down, the purple curve, because of course people are not surviving in the first year, in the second, third, fourth, fifth years. And so we have a lot of work to do. So we've done better quality of life, longer survival, but of course more to do. So one of the things that we're always wondering is this: what is the best first drug that you should be on? We have 10. Should you be on 1, 2, or 3? Now, clearly there's issues with 2 or 3. Cost, big issue, but we deal with that. Side effects, definitely more. And then there's some data that supports that. Some studies, but not a lot of great studies. A lot of this is being done just in practice. We've studied this in our own practices. It's kind of the session that just happened, this real world evidence idea, RWE. What's actually happening in practice? Are people doing okay with 1 drug or 2 drugs after a year or 2? And that's how we learn. It's not a study, but it's important data. And then at the bottom is a really important point. We all believe the prostanoid pathway, the prostacyclin that patients are missing, is really important. It might be the most important cause of pulmonary hypertension in many people. And yet it's not the easiest to give back. Intravenous, under the skin, subcutaneous are fantastic treatments. I say this every day to patients. If I had severe pulmonary hypertension, I'd be on those drugs today. But they're challenging. We know there's side effects, there's risks, and there's complexity you have to learn to look after. A syringe, a cassette, a pump, all that has to be done really well. And we know it doesn't always happen. Half of people every year have a problem. But that's okay. We teach them what to do when that problem happens. But they are fantastic medications. Used how often? Maybe less than 300 patients in Canada of the 5,000, 6,000. So a really tiny number because they're difficult. So we need new drugs that might work in those ways. And we have one, as you might know, Uptravi, a pill that's very good. But those are all still questions we're struggling with. Should we be doing infusions in more people? I think we'd like to, but they're not always willing because they're challenging. Now, in those 3 classic pathways that you all know well, there are some new ideas. And so at the top, you can see there's 2 drugs that we've talked about for a long time. The inhaled version of a prostacyclin called Tyvaso in the US, very widely used in many kinds of pulmonary hypertension, not only PAH that we largely treat in Canada. And yet it hasn't yet been approved in Canada. I don't know if it will. There is a lot of work still going on with our friend Alison McLean from United Therapeutics trying to convince both her company and the government to accept this medication for some people with pulmonary hypertension. So I was wrong when I said yesterday, I don't think it's going to come. It may come. There's a lot of work still to do. And we like it. As lung specialists, the lungs are massive and they absorb things very well. So inhaled medications are part of the future of pulmonary hypertension treatment. The oral one is available in the US. It first got approved probably 5-6 years ago, and it was unbelievable. I don't know how they got away with this. They priced it at $900,000 a year. I guess thinking it was the best thing ever. So it's not being used that widely. It's never going to get to Canada for that price. I don't think it'll actually get to Canada, but that's okay. Other things are coming. Nitric oxide I mentioned, there is approaches to you breathing in nitric oxide if you don't have it, just like oxygen. A little cylinder, a little nasal prong, and you walk around wearing nitric oxide. We were part of some studies that did show some benefits. So it's being used in the US in a little way, and so it's possible. I'm not sure I'm optimistic. It's challenging. One of the neat things that's happened is trying to help people's convenience. You take a lot of pills, I'm sure all of you complain about that, is can we make things simpler? And so recently Janssen has taken 2 of their medications, put them together into 1 pill. So instead of 3 pills a day, it's 1 pill a day. So it's a small advance, but obviously trying to help convenience. So those are the old pathways. So what about the new targets, the new avenues? So then we need to go back to the science. On the left side, that pink ring is the muscle in a blood vessel in our lungs, the pulmonary artery carrying blood to the lungs. And all around it, you can see the white space is the alveoli, the air spaces. So that blood vessel is wide open, lots of blood flowing. The wall is very thin. That's a healthy pulmonary artery in most of our lungs. On the right side, unfortunately, is pulmonary arterial hypertension and what's happened. And you can see the top example, just near the black arrow, there's a tiny little hole there where blood is flowing. And the bottom example, half that blood vessel is plugged up. So this is not a disease just where blood vessels go into spasm. That's an old idea. This is an example of cells not behaving themselves, growing too quickly, too fast, too big, and making new cells. And that plugs up the blood vessels. And so this is not going to get better in 5 minutes or an hour or 2. It's going to take a long time to act on this, which is why our medications take 3 to 6 months to get people better often. But the new medications also targeting this may also take longer to work. So why did that happen? Why did all those cells start to misbehave and grow and plug up the blood vessels that should be open? Well, this is an idea that's been around for a while. It's called the cancer theory of pulmonary hypertension. So cancers, cells grow without control. They don't listen to normal signals that tell them to behave. In pulmonary hypertension, this happens. And 2 main cells, muscle cells in the wall of the blood vessel and the endothelial cells that line the inside of the blood vessel. And so you can see the examples down at the bottom. At the far right, the plexiform lesion is all funny little channels of blood vessels because of endothelial cells. In the middle, it's called media thickening. That's muscle that's grown to thicken the blood vessel and block it off. And when cells are growing and misbehaving, the body reacts with scar tissue, and that on the left side is the fibrosis related to cells growing. So that's really what's going on. It's not a cancer, but it's like the growth of cells in cancer. So let's look at those things going on, and can we target those with our new exciting medications? And so these are the treatments. There's too many cells. Let's get them to behave themselves and stop growing and stop proliferating or making new cells. And so there's the list of medications. We're going to talk about a couple of those. They have funny names like TKIs. I know everybody's practicing saying seralutinib and Tatercept. Keep practicing, it's important. I also highlight at the bottom there, very important, a lot of the research that's been done on endothel in the past, nitric oxide was Canadian, even more research now in Canada is going on these new treatments. So let's look at a couple of these. About 20 years ago, 15 or 20, we had a pill that came from the leukemia world, cancer, and they tried it in pulmonary hypertension, Imatinib. And it actually worked really well in the sickest people with pulmonary hypertension. However, 1 in 5 roughly had bleeding in the brain. So obviously not what we wanted to use. So it kind of died out. We didn't use it. It's still used in some parts of the world occasionally. But what about if you breathe it in? Remember the lungs like to absorb stuff. Much smaller dose, maybe not as much side effect-wise, and hopefully just as effective. So that study is already going this year, brand new and very exciting. So Imatinib, you will hear more about the next couple of years. Now, I know you're all excited about Tatercept. Do you all want to try saying that? There you go, easy. And we are as well. So 2 big studies in the most preeminent journal we have, the New England Journal of Medicine, one in 2021 and one just a couple of months ago. Really, really exciting. This is a fascinating molecule, and here's a little bit of science. So remember those cells growing, making new cells, causing scar tissue. They don't just do that for no reason. They do that because there's chemicals in your body that are telling them to do that, and those are called growth factors. So they tell cells to grow. And you can see at the top left, there's a couple of examples. One of them is activins. The other one's called GDF, growth differentiation factor. So seralutinib is an antibody that's humanized, and it goes in there to actually sop up those chemicals, the activins, the GDFs. So if you sop them up, they're not doing their job. So Tatercept, sorry, thank you. So it's sopping up activins and GDFs. And so it's not there to do its work, and we think that tells cells to slow down, stop growing, and it might even do something positive on the other side where anti-proliferative strategies, cells have strategies to not grow cells, to not grow, not proliferate, those get cranked up. So it's almost restoring the balance of cells growing too fast and not listening to signals, turning that down, and turning on the normal signals that control cells. So the last study that came out was a big study, and it showed in people very much like you, who are not brand new to PH, or on 2 drugs, 3 drugs, some of them on the infusion therapies, they felt better. They walked farther. If you measured it, their quality of life was better. And they clearly were more stable and didn't get sick as often in terms of needing hospitalization or those important outcomes. So it's very exciting from our side. It also seems to drop the pressure in the lungs over a short time more than most other medications have in the past. So you will be hearing a lot about this. Sadly, it takes time. You heard this morning about advocacy. We're obviously going to start as soon as we can, but there's several governmental layers to go through. It's going to take 18 months, so it's not going to be quick, unfortunately. There was some side effects, not surprising, like any medication, some different ones, a little bleeding and some funny blood vessels that we're going to have to understand. Now, inflammation, we talked about it a little bit this morning. Inflammation also drives cells to grow. And there's a lot of inflammation we know we can measure in the lungs, in the blood. And there are pathways that we think we can turn off. Now, the challenge is some of these trials have been done in the past. You see there in the middle, Ubenamix, bardoxolone, drugs that worked on inflammation. We were very excited. They were completely negative. Didn't do anything to help PH patients, so they're gone. And this is important. You have to study things, even if it sounds promising, to show that they actually work for patients. So right now, we're at a couple of different ones. In there, apabetalone from our friends in Quebec City, again, Canadian. At the bottom, you can see dichloroacetate, also Canadian. Let me give you one example about this. So from our friends at Quebec City, they have shown that inflammation in the middle that's going on makes all that scarring and cell growth happen. And that leads, obviously, to the bottom, PAH. And in that mess of inflammation, there's 2 key molecules, 2 key chemicals, BRD4, you can see in red, and PARP1. And so with a tremendous amount of research in cells, in animals, human tissues, over 10 years plus, they have shown that those play an important part in PAH developing and getting worse. And they have developed drugs. On the right side, you can see 2 inhibitors that they have developed that work in animals, so olaparib and apabetalone, and so now these are entering clinical trials. So very exciting, and long history of work in animals and cells, finding things that play a role in pulmonary hypertension, and now getting to the point of trying them in people. So very proud of our colleagues in Quebec City. What about the other side of pulmonary hypertension you may have heard about? This idea that you actually, instead of having big blood vessels, which you do, you actually lose blood vessels. And the pictures on the right are very important from our colleagues in Edmonton, Dr. Mikalakis. On the top, what you see is a fairly normal MR, magnetic angiogram. So the main PA, pulmonary artery, and you see all the tiny little branches, like a tree ending up in tiny branches. That's normal, tiny little blood vessels that we all need to have our lungs work properly. At the bottom is a pulmonary hypertension case. The pulmonary artery, the PA, is bigger, pressure's high, but what's happened to all those tiny little branches? You don't see them. So this is actually loss of blood vessels. So even though they have bigger blood vessels, they've lost a lot of the tiny microscopic blood vessels. And so it's crazy that some cells are growing too much, but other cells have died and we've lost the blood vessels. And so we know that death of these cells is part of the problem. Earlier, probably, can we fix that? And this is the idea of cell and gene therapy that you've heard about for several years. So this is the study, again Canadian, the SAPPHIRE study led by our colleagues in Ottawa, Duncan Stewart and his colleagues. Many of us across the country are participating and we're very excited. The idea is all of us have stem cells floating around. They get to areas that are injured, like the lungs, and they try to fix it. So what if we took your stem cells, because you still have them, make them better and give them back to you? Can we fix your blood vessels? Can we grow new blood vessels? That happens in animals. It happens in the lab. Obviously, it'd be fantastic if it could happen in patients. So this study is going on. We have a couple of patients left to collect the data. Sadly, it's been stopped prematurely. We were supposed to do 45 patients. We only got to, I think, 15 or 16. And it's because COVID really made it very difficult to get people in during the study, and the company sponsoring this obviously is struggling with the costs of it. So it's going to end early, sadly. But we will have information, and that information is going to help us go forward with the next study on gene and stem cell therapy. We can chat about that some more. We've talked a lot about what's going on scientifically in the lungs at the top, the biology of PAH, pulmonary arterial hypertension, and that's critical. But you may have heard, or you may know, that's not the most important part of how you feel, how you're able to walk, and how you survive. That becomes a problem of the heart. So pulmonary hypertension, lung disease becomes a problem with heart disease, especially the right side of the heart goes into heart failure. And that's a tough area. We don't have any treatments essentially for the right heart right now. A lot of exciting research we heard about on Friday with our medical think tank, but you're going to hear a lot more about specific ideas about how to improve the right ventricle. In fact, our research building capacity with Dr. Weatherald, that's one of the focuses, is let's look at the right ventricle. Can we make the heart work better and keep it going longer in people that don't have any other treatments for their pulmonary hypertension? You all know this. When you get sick, take an antibiotic, doesn't always work. It worked for him or her, how come it didn't work for me? And it's very clear that drugs don't work in everybody. We're not the same, obviously. Even though we might have the same disease, we are incredibly different genetically, environmentally, socially. All of those things determine how a disease acts in our bodies and how a medication acts. And this is an idea of precision medicine that is the future of medicine. In fact, it's already happening in other areas like cystic fibrosis and cancer care. So the idea is, if you look at this really nice study from 2001, if you look at common disease areas, depression down to asthma, cancers, a single medication only works for somewhere around 30 to 70% of people it's given to. So it's a bit of guesswork, 50-50. That's not good enough. And so the idea of precision is knowing you, not just your name and where you live and how old you are, but knowing your genetics, knowing your environmental background, your growth, and maybe some special measurements in the body. I say, you know what? I have a better idea. Compared to the standard idea where I give the top panel treatment A to everybody and maybe 20-30% get better, what if I have 4 treatments at the bottom, A, B, C, D, and I say, you should get A, you should get B, you should get C and D. So this is the idea of precision medicine, knowing your genetics, your biology. Why do you have this disease? What are the chemicals in you that are making it happen? And can we treat that? People also use the word personalized medicine. I don't actually like that. I don't think it's correct. Personalized is what we do now. We meet you, we understand you as a person, what's your background, do you have scleroderma or not, have you taken medications before? That's personalized. This is more, this is scientifically precise medicine. And so all dependent on genetics, which is going to be a big aspect of future research into pulmonary hypertension. So with that, I'm going to pause. I'm going to introduce my esteemed panel from left to right. So Lisa Lee Kochman is a fantastic nurse practitioner in the UBC Vancouver Pulmonary Hypertension Clinic for many years, and Lisa has become independent in looking after the sickest people on all the prostanoid infusions. Also recently, wonderful interest in the genetics, the testing of pulmonary hypertension, and how to manage that. So we'll definitely have a good chat about that. David Langley, many of you know, I call him the father of pulmonary hypertension in Canada. Been doing this longer than I have for sure, probably close to 40 years now. Was one of my mentors at McGill when I first got interested in pulmonary hypertension, and still a wonderful valued member of our community. And then on the younger side, Dr. Thacker from Calgary, one of our young PH docs. Great to have him. He works in a very strong group in Calgary, and so there's our panel. So with that, I'm going to start off the questions first and foremost. Lots of potential possibilities. Lisa, we'll start with you. Before we get to the specifics of genetics and that, 5 years, what do you think is going to be the most exciting new direction in treatment for pulmonary hypertension in the next 5 years?
I think that's a great question. I think honestly, though, from a patient level, it's being able to change the mindset that treatment, or us asking you to start on treatment, is a failure. Like somehow you've gotten worse and now you need medication. And I think honestly, what's most exciting about the next 5 years is that the medications are actually a solution, and therefore something that you should be excited about. So, you know, a lot of times we look at, you know, we're checking in to see how you're doing and seeing if your disease has progressed since we last saw you, and then based on that progression, making decisions to start you on medication. Fortunately, we're accumulating more and more evidence to suggest that instead of taking that kind of approach, meeting you early in your disease course and starting medications earlier and giving you options early so that we aren't waiting for the disease to progress. So I think, honestly, from your level, if that's something that you as a group of people can help embrace and change that kind of culture, I think we potentially can go a long way as a group of people to treating pulmonary hypertension.
I think that's a really important point, not just hopefully diagnosing earlier for many things like screening, looking for pulmonary hypertension in some populations like scleroderma, but you may have heard this concept of biomarkers, measuring things in blood that tell us the disease is coming or already there before you actually get sick, and makes it easier to diagnose earlier. I might just add to that, the other thing, people are always cautious about adding a second and third drug. Patients and families are hesitant, side effects, all those things. That's where I think we often realize that we need to be more aggressive. There's not a single drug that you have available that cures anybody. And we know 2 is often, not always, but often better than 1, and 3 often is better than 2. So it's being aggressive earlier, which isn't always, I know, a preferred option for patients, but I think very important. David, I'll turn to you next. You have a mic there? And so most exciting thing treatment-wise in the next 5 years?
So it's wonderful, I think, to be able to finish this meeting on an upbeat note. Because from where I stand and where I see things going in 5 years are novel therapies. And we have new ones that are quite successful, are going to completely change the way we approach treating PAH. Professor Mehta showed you a tree. And you have to imagine a tree, the human lung, circulation, with the leaves at the end. And the leaves are our capillaries, where the gas exchange takes place. And you know, when you see a maple leaf on the ground, the twig just before. Well, we have probably 100,000 to several 100,000 of those little twigs. And then we have about 900 million capillaries, leaves, okay? As you're sitting here, you're using about a third of them. The others are just sitting folded up. Well, I'm using an analogy. They're not really folded up, but they're just not being used. They're available, but they're not being used. And what happens in PAH is that the twigs just before the leaves get very diseased, and Professor Mehta showed you those blocked little vessels. We call them microvessels, okay? They get blocked to varying degrees. Some are mildly blocked. It's a progressive disease. Not every vessel is attacked the same way. Some are fully blocked, some are mildly blocked. And then the concept of loss of these vessels. In fact, they're not lost. What they are is they're just not seeing flow. And no matter what we do with our pills right now, We can't push more flow through. So how are our pills helping us? The way the pills help us is they do allow us to have more flow, which is what our body needs to live and to help unload the right heart. But they're very likely just using the less diseased vessels and having almost no impact on the more diseased vessels. And we have evidence for this. We have evidence from patients that lived 20 years on our best therapies and then passed away in car accidents or from cancer. And people took a look at their lungs. And their lungs were every bit as blocked as they were on day one. And yet those people were doing well. And the reason they were doing well was because our medications, which are a godsend, are allowing more flow to go through the less diseased arteries. Think about a bathroom drain, okay? It can get quite narrowed for a while before it finally slows down and stops. And so you have to imagine 100,000 or more bathroom drains in here, some fully blocked, some partially blocked, some very mildly blocked. And the medications we're giving, in essence, are sort of filling up the sink, and by the pressure in the sink, maybe forcing some more flow through the ones that are less blocked. And when you look at our clinical studies right now, they're very good at improving the flow, but they're doing it because the pressure still stays high in most cases. And that's our current model of therapy, and it's serving very well, and we have people living, I'm happy to say, 20 or 30 years. What I envision in the next 5 years are that these novel agents are finally going to start acting on the fully blocked drains and on the severely blocked drains. And the good news is that the leaves are still there. They're not dead. They're folded up, they're waiting, and every time we study them, because this is what my research is, every time we study them, they are available for flow if you can restore flow. So our challenge is to find agents that are going to unblock the drain, and they're going to be different. They're not going to be vasodilators. As Professor Maida said, they're going to be things that attack the sludge in the drain, those cells, and make them disappear. They don't need to disappear 100%, but they do need to disappear and restore the channel, okay? What's that going to do? It's going to give something different, because suddenly there's this, sigh of relief, and the blood can go down into the leaves. When that happens, the pulmonary artery pressure is going to fall. Because like your drain that unblocks, you don't need your sink to be full anymore to force the water down, okay? And the sink will empty itself. And that's what we have to be looking for in the next 5 years to call a therapy successful. We are already seeing it. If you look at the results of that stellar trial, I have a fan. Okay, if you look at the results of the stellar trial, it's a very unusual result, but it's the most encouraging result I've seen in 20 years. Why? Because the pressure fell in those patients. And every model of pulmonary hypertension we have in humans where the pressure falls, people return to normal. Whether it's pulling out blood clots, whether it's finding people who respond to high-dose calcium blockers, any of those types of diseases, okay? The downstream flow is still there, and it's just waiting to be used, okay? So look for successful agents to cause a fall in pressure. They're not going to cause much of a rise in resting blood flow because all of our other agents that our patients are on have already restored that blood flow. It doesn't need to get more normal than normal. Okay, it's not going to, but the pressure is going to fall. Okay, and that's what I'm looking for in all these agents. And the other thing to remember is we don't need to open 100% of the drains. People do very well with 50% of their drains open. They won't do Olympics. They may not do competition cycling, but they will function completely normally and have really almost a normal prognosis. I'm talking about normal prognosis. Now, the disease may not be cured But as Dr. Maida said when he talks about a cancer, we would love to have people in a 50-year remission. Now, that's my dream, okay? But I'll take a 50-year remission. And as long as we can end up controlling this and keeping the drains unblocked, we're fine. I'll pass it on.
Beautifully said, David. Thank you. That's a tough one to follow, Mitesh. Good luck.
Yeah, right? I need another 30 years in this job. Sage advice, yes. You know, I was thinking about this too, and I mean, the other hat that I wear as I'm a pulmonary hypertension specialist, but I'm also a lung transplant physician. And through this weekend, you know, and reading before, one of the things that I think is a really good analogy, and Dr. Maida, you said this as well, was our cystic fibrosis colleagues, right? So our CF colleagues understood a gene, and they had it easier. They had one gene to worry about. We've got many. But they understood that there was a gene that was a problem. And if you could fix that genetic problem, either by modifying DNA or probably more easier to use a medication to solve that problem, you cure the disease or put it into a 50-year remission. And that's exactly what my CF colleagues have done, is they've put cystic fibrosis into remission. My CF colleagues tell me as a lung transplant doctor that we don't need you anymore. In fact, we probably don't even need ourselves very much more because we've cured the disease. And so you'll never see another CF transplant patient, is what they tell me. And I think we've certainly seen that transition. Many of us that do PH do lung transplant as well, because 20, 30 years ago, that was all we had. And so it was a natural synergy to be a PH doc because you're just going to see them in the transplant clinic. And certainly we've seen less and less patients coming to lung transplant over the years, but it's not zero. And I think as we start to get more precise with our medications, as we start to understand which genes are turned up and which ones are turned down, and how can we modify these through pharmacology, my suspicion is we're getting to that point where we can start to think about remission. I agree. I don't think there's any more point in beating pulmonary vasodilators. We've done that and we've maximized that. And if we can put these things into remission, then that's my hope, is that I actually don't ever transplant somebody for PAH anymore.
Very well said. So I have a few other questions, but definitely want to open this up as well. There are a couple of mics with our staff. Anybody have questions from the audience? Yeah, please, Steve.
Thank you. Hey, when you docs talk about the precision medicine and on those options, you know, on the graph of, honestly, it was kind of shocking to see different disease states, how the efficacy wasn't great. But assuming that you have, you know, for patient X, this is going to be great for her, this is great for her, this is great for him. What is the challenge to navigating when you talked also about therapies that might not get approved because of costs or whatever? So when you're like, you know that this is going to be the precision one for her, but that's not available, or, you know, a company may prefer to do a tried and true therapy. So how do you navigate that moving forward?
So I think that we need again to look at our cancer colleagues. Because if you look at the current treatment of breast cancer and lung cancer, it's now highly personalized based on receptors, genetics, a bunch of different things that say to a person, you're going to respond to A and not B, okay? And therefore, we're going to get you A. And I'm saying this proudly, Canada's been generally excellent at supporting treatment A for a patient that needs treatment A. I don't view that as a barrier. I think the more therapies, the merrier. We will have to sort out who responds to what. And then I think the governments are going to line up. And part of that argument is that they may need only one therapy instead of 5, which is, you know, economically advantageous for them. And so I don't foresee that as a hurdle. I actually foresee it. You know, Lisa gave a wonderful talk yesterday on genetics in a clinic, okay, and how that will begin to direct us towards personalized medicine and understanding. And people shouldn't be afraid of genetic analysis. The more you know about your disease, in my view, the more you know about your disease, the more it empowers you. It places a greater burden on us because then we have to come up with a therapy for the specific problem, but that's a happy problem in a way, okay? So I think that I don't see that as a hurdle, but.
I'm just going to add something, Steve. I think that's absolutely true. The other thing is, like I showed you there, if 80% don't respond, why are you using it in those people? So we're going to be stopping therapies when people aren't going to get better from them. So definitely a cost saving, less side effects. The other interesting thing is if you do a study of 500 people where many people aren't going to respond, that's a waste of incredible resources. That's why drugs are expensive, because studies are expensive. So if you could do the study with 100 people that are picked out to respond to the drug, cheaper studies, cheaper medications, less waste in the future. So I think it's actually a real positive, being more focused. Also want to get Lisa to chime in on this.
Specifically about genetics?
No, yeah, absolutely.
Okay. Yeah, I mean, so you were talking about a case series that I presented yesterday. You know, I have 3 patients who originally were diagnosed with idiopathic pulmonary arterial hypertension, meaning you have pulmonary hypertension and we don't know why. With genetics, you know, that category of patient over time is likely going to disappear. So, you know, you have a type of pulmonary hypertension where some part of your pulmonary vasculature is affected. So some part of the veins or the arteries in your lungs are affected. And this is going to be the specific treatment for this type of pulmonary hypertension. And again, this is all very new. And, you know, it's just the beginning, but it's like you're on the cusp of an explosion in terms of treatments for understanding and also, like I said, treating pulmonary hypertension. So, you know, for those of you who are my patients in my clinic, it is something that's currently available in BC. We have to be very careful and judicious with our use of it so that when we're using it makes sense. But if it is something that you are interested in, don't hesitate on your next visit to the clinic or to send me an email. And the other thing that I want to share with you is this initiative in BC was actually driven by patients. So, you know, understanding your role in getting us interested and getting us to put in the resources, you know, for me, I was always kind of thinking about doing it in the background, but it was a specific patient family that said, hey, look at this, there's something going on, we need to do it, and now we're doing it. And I'm really, you know, in all of the competing, you know, I'm a clinician, I'm not a researcher, so I'm not sitting around thinking about treatments for pulmonary hypertension. You know, I'm dealing with people whose lines are falling out, or who are in heart failure, or are having troubles breathing and need to be diagnosed with pulmonary hypertension urgently. So, you know, if you see something and you think that we're missing it, as much as we have the capacity in our clinic, we can try to figure out a process for it, or refer you to somebody else who's already doing what we're doing, as long as that makes sense. Okay.
Yeah, I was just going to echo that. I think you know, one of the barriers we will face is the financial realities of getting, you know, new drugs to market. And if you're shrinking the patient population in whom you're going to apply that drug, obviously becomes a bit more challenging. As Dr. Mehta said, you can get more efficient with that. So your trial costs might go down, but conversely, your market size goes down as well. And so I think we have to be cognizant of that financial reality. But I think we've seen it time and again in other rare diseases that if you have something that truly works, even if it's on a subset of patients, it gets pursued, right? And so I think, and it comes because we as the medical community push for it. We push regulators, we push pharmaceutical companies, we push ourselves in our university labs to continue to pursue something that looks positive. But equally, these drugs come to market and are accessible on the market when patients push for it as well, right? So I want to echo Lisa's comment that a huge part of that success for rare disease management and treatment and ultimately remission comes from all of us working together to solve that problem as opposed to only one of those channels speaking up.
Question?
Oui, une question en français.
Absolument.
Oui, vous avez parlé des débits sanguins au niveau des artères, des poumons. Puis si le débit sanguin augmente avec un produit qui s'appelle comme l'apabétalone, que le débit, au lieu d'être à 5,6, tombe à 7,2, puis que la personne se sent mieux. Quand est-ce que les prochains essais vont avoir lieu pour l'apabétalone? Avez-vous une réponse là-dessus?
So the question is there's early studies with apabetalol that seem to suggest benefit. When's the next step? La réponse que je vous donne, c'est vous devez demander à Dr. Provencher, parce que c'est lui vraiment qui contrôle l'étude. Je ne sais pas, on n'est pas au courant des plans. So we don't, Dr. Provencher is designing and running the studies. I don't know what stage he's at now. It seemed a year ago or so that we might start to get going, but again, I haven't had more news recently. You just have to ask him. Write his center, contact his center and ask him, please.
Ce qu'on a compris, c'est, vous comprenez peut-être, il y a plusieurs étapes avant qu'un produit soit capable d'être dans un essai clinique. Et donc, sont en train... Hein? Oui, c'est le phase 3 qu'on attend, mais ça commence avec phase 1, phase 2, phase 3, ça prend du temps. C'est les premiers essais dans des humains, donc ça va aller au moins 3 à 5 ans avant qu'on ait des informations que ça marche dans l'hypertension pulmonaire pour être capable de parler pour un traitement. So what I'm saying is research is slow, sadly. Not only the basic science takes time, easily 10 years plus, then the clinical stuff starts, phase 1, phase 2, phase 3. So we're looking at these treatments coming from Quebec City in 5 years, optimistically as a possible treatment, but that's a long ways away. And lots of treatment during their phases doesn't work or has bad side effects, so we lose those medications. Pendant les 5 ans aussi, monsieur, à cause des effets secondaires, à cause d'un manque d'efficacité, on les perd. Ils arrêtent d'être produits. Donc, on ne sait pas que ça va arriver à 5 ans. Sorry, other questions?
Oh, yeah,
Please.
we have one from online.
Oh.
Julie McCuska wants to know, what about, I'm going to mix this up. What about research into rituximab?
Rituximab, anybody have experience or ideas?
There are a variety of agents that affect the inflammatory system that are under evaluation currently or will be under evaluation. I know our rheumatologic colleagues are paying a lot of attention to this. It may yet come to a PH trial, and I'm trying to remember, I think there may be something underway, but there will be many of the different agents. We're going to have an explosion of potential therapies. Our problem is not going to be a lack of potential therapies. Our problem is going to be a lack of patience and study time to get all the questions answered. That's the real issue. And so, you know, anyone here that can get into a clinical trial, I encourage you to do it. You're always the astronauts. You're the ones trying something new, okay? But you're doing it for yourselves. You're doing it for the future. You may be doing it for your children. So these clinical trials are critical. It's our job to try and pick and choose amongst the various horses as to which ones are likeliest to win the race as quickly as possible. Sometimes we're right, sometimes it's a bad bet, but it's most of the time the reasonable bets, and that's going to take time.
There was a lady in the middle in purple. Maybe that's not helpful, in purple.
Thank you.
Hi. I'm really fascinated with what I think Lisa said about idiopathic patients that had genetic testing. Being an idiopathic patient myself and having 2 children and knowing that the sooner this disease is recognized and your treatment starts, your better your prognosis. I'm just wondering, how do we go about getting this sort of testing?
Where are you located?
I'm in Ottawa.
Okay, so what you're going to do is when you get home or when you're next visiting the clinic, you're going to bring this up with your provider. So the interesting part about the Canadian medical system is that each province is a little bit different. So in BC, what happens is when we identify someone who we think should go for genetic testing, I speak to them originally for a few minutes to see if they're interested. And then we set up an appointment and we talk for about 20 to 30 minutes about what's involved in genetic testing, what's going to happen. And then I need to submit a piece of paperwork to the government funding agency to ask them if they will pay for the genetic testing. And then that takes about 2 weeks to get an approval letter. And then when I have that approval letter, I go through a very thorough consent process to discuss, what are the possible results and what potentially could happen if you get a genetic result. And then we draw some blood. And in my particular case in BC, we use a fantastic, excellent genetics laboratory in Finland who's on the cutting edge of looking at genetics and pulmonary hypertension. And they give me a report about 4 weeks later, and then I discuss those results with you, what that means in terms of, the type of pulmonary hypertension you might have, what that means in terms of how severe the disease might be, what it means if your children also have that gene, because there's a good chance that some of your children will not carry that gene. And then if they have that gene, what's the likelihood over the span of their entire life, whether or not they'll develop pulmonary hypertension or not, okay? Oh, cost to government. So again, BC specific. How we've worked it out in BC is that if we're testing for idiopathic patients, it's looking about $1,500. A single gene is about $600. I absolutely 100%, there are mechanisms in BC for people to pay privately, but I would encourage you not to go out to yourself and approach one of those kind of sorry, this is probably not acceptable for me to say on here. You don't want one of those fad pop genetics companies. You want to pay for the same testing that would be covered by the government. And the reason is genetics is extremely complex. So there's a lot of information on extremely large computers that have to work for long periods of time. The amount of information that they're looking at is just phenomenal. And if you pay a little bit of money, you're going to get a not very helpful result. So go through your official channels, Again, you have to be very, very kind to the physicians and nurses who are just, this is just coming into clinical guidelines now. So a lot of people over the next couple of months, are going to be having to figure this process out. And like everything that's new, it takes time to navigate the systems, to find someone to pay for it, to figure out the process that it works. So I can tell you it took me about 2 to 3 months when I decided to do this to figure out how to do it, and then figure out how to put that into your own already full workload. So, if you're interested, absolutely pursue it, but yeah, be kind.
Thank you very much.
We have a few more minutes. Other questions? Des autres questions? On a juste quelques petits instants qui nous restent.
Is this on?
Yes.
Hello. We mentioned the fact that there may be a great many clinical trials and not enough patients to actually meet the need on those clinical trials. How do we have a lot of patients who are currently not eligible for clinical trials. How or what process, is there a process that is going to happen to allow some of those currently ineligible patients with comorbidities or with pre-existing conditions like congenital heart defects, to have access to some of those clinical trials so that we can find more patients to be on clinical trials.
Mitesh, you want to tackle that?
Yeah, sure. I can start, and I'm sure others can contribute as well. Clinical research I think what's really important to remember is, just because one is not eligible for a pharma trial doesn't mean they're not eligible for research, and doesn't mean that there isn't a contribution that we can all make, right? And I'm not a researcher. I don't have a lab, but I love participating in what projects people have, and these projects can be quite varied, right? I mean, equally as important as finding the next drug is how do we make patients feel better now? What interventions can we have that help you today? Those can be things like exercise programs or other devices that might help with just quality of life. And many of us are involved in clinical trials like that, where the inclusion criteria are a bit more broad than a pharmaceutical-based clinical trial, where you have to isolate the one condition that you're interested in. The other bit of clinical research that we're all involved in across the country is the Canadian PH Registry, right? And so all diagnosed patients with PAH or CTEPH would be eligible for that, regardless of what other comorbid illnesses that they might bring. And again, that's very, very helpful real-world data that we can then use to inform what we do here locally in Canada and around the world. And so there are ways to still participate in research even if one is not eligible for a clinical trial in the truest, in that sort of pharmaceutical sphere.
I just wanted to add, Joan, it is a challenge for companies to respect what they do. If they take a drug and give it to 100 patients, half of whom have other, as you said, comorbidities, lung disease, heart disease, things like that, if the drug may not work in those people or might have side effects, that drug might never get developed, and we've lost it, whereas it could have helped many other patients. So studies have to be appropriately narrow in their criteria for who gets included and who gets excluded. It is a problem that we've dealt with always, but I think it's important.
I think I understand that, but I also we've already discussed on the panel the fact that idiopathic pulmonary hypertension is just hypertension where we haven't actually figured out what the cause is. So there is also, for those patients, there is also a underlying cause that could technically affect the ability of that particular new therapy to detract from the results or affect the results.
Yeah,
and so I
absolutely.
get that, you want to eliminate the confounding factors, but the reality of it is idiopathic patients are still confounding factors.
Are still confounding factors. Very true. And so obviously there's different levels of confounding factors, but then also go back to what you presented earlier, real world evidence. A drug gets studied in a tiny number of people, 100, 200, maybe 500. If it gets released, it's going to be given to 1,000, 2,000, 5,000 people that don't meet the same criteria. So we will learn a lot more, sometimes negative, side effect wise, but sometimes also that it does work in those larger populations.
I just want to say, oh, thank you. And I guess that is the perfect answer that I actually needed to actually say what I'm about to say. The reality of it is that's why it's so really important for patients to understand how important their data is because if you are not eligible for the clinical trial and you get that drug after it has been approved, you are still providing evidence for the continuation of that drug or for the extension of that drug into other patients.
Absolutely. Any other final question? Okay, well, maybe then I'll thank my panelists. Thank you, excellent colleagues and ideas. Thank you. And then we'll bring back our fearless leader, Jamie.
Thank you so much. Okay, thank you so much to our panel. This is always my favorite session, and I always think it's just the perfect way to end this weekend with a look at the future and all of the reasons for us to be hopeful. So I'm going to make a plug for a couple of little things and follow up to today's session. The first is something you can do right now, today, and that is when you leave to visit the Tulip Wall outside. The programs committee has given you a space where you can express what your hopes and dreams are for the next 5, 10, 15 years for the PH community. And since PHA Canada is currently going through a strategic planning process, it's an opportunity to directly influence the plans that we're making and how we're going to do our work moving forward. So a little plug for the Tulip Wall. And then also in the coming weeks, hopefully, knock on wood, we're going to be coming to you PAH patients in particular with a survey. We're partnering, PHA Canada is partnering with an academic research center at the University of Alberta with Jason Weatherall as our principal investigator on a study looking at the socioeconomic burden of illness in PAH patients in particular. We currently don't have any clear numbers. We have lots of evidence from our own surveys and your own experiences that, PAH has a negative impact on people's ability to work and do other daily activities, but we don't have any hard numbers in Canada. And so this is going to be our opportunity to put some hard numbers on what that economic impact is when folks have a PAH diagnosis. So it's going to be a really important example of that real world evidence that helps us, that is going to be used in our advocacy efforts to continue to advocate for new therapies. And so I'm right now, before it's even been released, I'm just telling you to get ready for it and hoping that you'll complete that survey and help us out with that research. So now it's a time to wrap up our weekend together. I want to again thank a whole bunch of people. I know we did it this morning, but I really think it's worth doing again. I want to thank all of our speakers and our moderator extraordinaire today, Sanjay. I want to thank all the volunteers, in particular the planners who put together such a fantastic program tonight and last night. I want to really, they probably are getting tired of me thanking them at this point, but just cannot cheerlead my team enough, and that includes Ethel, who's not with us today, but Kim, you've done an amazing job for your first time around. Thank you so much. And it truly was a team effort. Everybody has pitched in for months, and especially this, in the weeks leading up and today. So thank you to all of you for all of your hard work. I finally want to again thank our sponsors, our gold sponsors, Janssen, Merck, and Shoppers, our silver sponsor, United Therapeutics, and our gold sponsor, Bayer. And then as well, our other supporters who, like I said this morning, really helped bring people together and make this a special weekend. So the BC PHS Society, #PQ, CC Squared Photography, and the Girl Guides, who, from what I can tell from the pictures I'm getting, have done a fantastic job upstairs in the kids zone today. And then finally, a little shout out to our translators, our interpreters who are online with us, and the AV and tech people who really helped make this hybrid event possible and ensured that our Francophone community could participate both here and online. So thank you to you for your work today as well. Now comes the really good stuff. First, if you haven't already heard the rumors circulating, I'm proud for the first time ever to be able to announce the location of our next conference at the end of a current conference. I feel like this is something I've been wanting to do for a long time. So I'm very happy to say that we will be having our next Western Canadian Regional Symposium in Calgary next September. We don't have an exact date yet. We're really close to an exact date, so watch out for the save the date, but it'll be in the later half of September in Calgary. unlike this event, which which had a scholarship program that served the entire country, it'll be like some of our previous regional events where the scholarship program will be limited to folks in the West to ensure that people can get to an event closer to their home. That being said, you're all invited from all over the country, and I'm just looking at Jazz and thinking, like, this woman has traveled like this whole continent to go to every PH conference there is. So I know she'll be in Calgary, and I hope some of you from the Atlantic will be there too. In order to help make that event the best event it can possibly be, there's two things that you can do to help support us right away. The first is to fill out your evaluation form. You'll be receiving an evaluation by email next week. We take these evaluations very seriously. We look at them, we use them to help to figure out how we can make changes and improvements to everything that we do. So I thank you in advance for please taking a few minutes to fill out your evaluation form. And then next, although we have amazing sponsors and supporters, this event still costs a lot more money than they give us. And so if you feel you've benefited, if you feel you can give, I would really encourage you to make a donation, a tax receivable donation to PHA Canada. You can donate anytime online, or you can donate, there's donation cards in our organizational brochure at the information table. Small donations make a big difference, especially when they're given monthly. So this is also my plug to consider becoming a monthly donor. We have lots of monthly donors who give $5, $10, maybe $20 a month, but it really, really adds up, and it gives us a consistent revenue stream that we can depend on moving forward. So just my one ask that I'll make this weekend to give if you can. And now the really, really good stuff, I'm gonna call up Kim, and we're gonna just make a couple of presentations. The first is for the scavenger hunt, the winners of the scavenger hunt. So we're gonna do a little draw, and then we've got some gift bags that include a bunch of goodies. So how are we gonna draw?
Any last minutes?
Last minute scavenger hunt playing cards? Oh my gosh, okay, so this doesn't feel fair to the person on top, so I'm gonna mix them up just a little bit. Okay, so.
Sandy, would you like to grab one too? Sure.
Okay, so I'm gonna grab the first one.
Names at the bottom on the...
All right, the first winner is Cindy Alvarez. Yay, Cindy. If you don't wanna come all the way up here, we can bring it to you, but come grab your, and then the next, Adrian Shatford. And last but not least, Vanda McLean. Oh, I think we just covered the whole country there. That was really good. I love it. All right, well, thank you for playing. I hope that you made some new friends and learned some interesting things about each other. All right, two more things. Remember that really great painting that Caitlin made? That she hoped would maybe, get a donation of $15 or $20 to PHA Canada? Well, I'm very pleased to say that you guys have done much better than that. So, our winning bidder for the Sometimes It's a Zebra is Natalie West. Congratulations, Natalie. You get to take home this beautiful painting. We'll run your credit card if you don't have enough cash. No worries. No worries. All right. And finally, we're gonna make her come up here one more time. She's already mad at me. I made a few comments yesterday at the AGM, and I started to get teary, and I said I would save it for today. I don't want us to be here for much longer. I want you to be able to go, and I want to give Sanjay a moment as well. But as I'm taking the prerogative as executive director to just take a moment to acknowledge Nicole for all of her work for so many years, not just on the board of directors, as an ambassador, as an advocate, as a supporter of so many in the community. Nicole has been a very dependable and thoughtful partner to me as the executive director in her role as board chair. She's always been supportive, always been available, always been reliable. And for all of her moments where she doubted her ability to do this job or whether or not she was having a real impact, I can tell you personally that I've seen the growth of our organization thanks to your leadership. I've seen tremendous growth in how our board works together as a team and how we, with the staff on the board, work together. And that is in large part to the example that you've set and the leadership that you provided. So I just want to thank you so, so much. And now I'll let Sanjay do the same thing because I'll just start crying.
Thank you. Well, absolutely echo everything Jamie has said. Just to add one other little thing, we as caregivers are always impressed by the courage of people like you. Patients, caregivers, this is not an easy illness, as you know and as we know. And yet, to do something like Nicole, look after yourself, look after family and say, what more can I do? An ambassador, board director, our first ever patient chair. That is unspeakable. So thank you so much for doing that. And she set the bar very high, and now we have 2 patients on the board. So we're so excited by that. So come on up.
I'm going to take a page out of Roberta's book from last night. Thank you.
And thank you, all of you. Thank you so much. I hope you've had as wonderful a week as I have, and safe travels home wherever that may be. Good night.